Good morning, good afternoon, good evening, wherever you are. Welcome to Virtual Grand Rounds. I'm your host this week, Eric Lim, and it's a great delight for me to present two presenters today. The first is Dr. Kathryn Arbour from the Memorial Sloan Kettering. We're going to be talking about KRAS mutations. This is a very hot space in the oncology field at the moment, and no doubt will greatly impact and influence what we do going for the future. And our discussant today is going to be Dr. Adam Januszewski, who's a medical oncologist based at Barts with a lot of experience in KRAS and the current ongoing KRAS trials. This is Premier Education brought to you at no cost, thanks to our sponsors, AstraZeneca, Medtronic, and Medela, the Science of Care. And without further ado, I am going to start the recording for Dr. Kathryn Arbour.
Hello, my name is Kathryn Arbour. I'm a thoracic medical oncologist and member of the Early Drug Development Service at Memorial Sloan Kettering Cancer Center. I'm here today to talk about KRAS mutations, cancer, focusing on targeted therapies for those patients with KRAS-G12C mutations, and also thinking about future directions about how we'll expand our targeted therapy beyond G12D mutations. KRAS mutations are common in non-small cell lung cancer, is present in about 25 to 30% of patients with non-small cell lung cancer. The most common mutation subtype is KRAS-G12C, which is present in about 12% of patients with non-small cell lung cancer overall. Increasingly, we see importance to recognize what specific non-G12C mutation patients have, such as G12D or G12V, as these may have therapeutic implications, but about 60% of patients will have a non-G12C alteration, and currently we consider these not targetable. We know that KRAS mutant lung cancer is a heterogeneous disease and can be defined not only by mutation subtype, but importantly by co-mutations. For example, P53, STK11, and KEAP1 co-mutations are common, and specifically those patients with KEAP1 and STK11 mutations have particularly poor outcomes, and these can lead to dramatically different differences in overall survival as well as responses to therapy. In this series on the left of patients treated with first-line chemoimmunotherapy with KRAS-G12C mutations, we see particularly that those patients who have a concurrent STK11 and KEAP1 mutation have particularly poor outcomes. It's also been shown with targeted therapy that those patients who have a concurrent STK11 or KEAP1 mutation in particular, have a shortened progression-free survival while being treated with targeted therapy medication. So these are important co-mutations that we think about. They don't necessarily guide different treatment decisions, but I am more worried about these patients when we identify these co-mutations. So RAS proteins are incredibly important in the cell. They essentially link upstream receptors at the cell surface to downstream signaling pathways that regulate everything from cell proliferation, migration, survival, and metabolism. We also know that KRAS signaling affects changes in the tumor immune microenvironment and can lead to a tumor immunosuppressive environment. G12C inhibitors were the first targeted therapies that we have, and when we think about RAS, it is a GTPase that cycles between an inactive GDP-bound state and an active GTP-bound state. These G12C inhibitors that I'm showing here on the left essentially bind to and occupy a pocket in the switch II region of the mutant RAS protein in its inactive or off state, essentially trapping the mutant protein and locking it in this out state, preventing downstream signaling. We have two medicines that are furthest along in clinical development that are at least FDA approved in the United States, sotorasib and adagrasib, though there are many others in development. Really, all of them are inactive state inhibitors or switch II pocket inhibitors, that there are additional agents currently in development that are more novel approaches. What are our early results of G12C inhibitors? Well, sotorasib was the first time we saw that we could turn a target that was long considered undruggable into druggable. And in this series of patients with non-small cell lung cancer, response rate of 37% was noted, with a median progression-free survival of 6.8 months. Results from the adagrasib phase 1/2 clinical trial came later, showing a response rate of 43% and median progression-free survival of 6.5 months, so fairly comparable. And more recently, we've had the results of the clinical trial of divarasib. This showed a higher response rate of 53%, but was most notable here was a longer progression-free survival, significantly more durable responses, with a median progression-free survival of 13.7 months. We actually eagerly await the results of a randomized clinical trial trying to compare these agents to determine which is our best-in-class inactive state inhibitor, and that will, I think, give us more information about the durability of response of these agents as a class and by individual agents. So the challenge for G12C inhibitors is that they can work exceedingly well, but not necessarily in a durable way. So this is an example of a patient of mine who was treated with first-line chemoimmunotherapy, which can still be very effective for patients with KRAS G12C mutant lung cancer. After progression of disease, he was started on second-line sotorasib. Pretty soon after it, within days, his cough, shortness of breath got better. He got back to work as a bricklayer, recovered from the side effects of chemotherapy, and was feeling quite well. 6 weeks after the start of sotorasib, we see substantial improvement in terms of his dominant site of disease, which was certainly encouraging, and we continued on sotorasib. Unfortunately, 8 months after sotorasib, we start to see that this site grows again. And so it's not necessarily that there's a substantial portion of patients with sheath storage don't work at all. In fact, the disease control rate is very good. It's more of a challenge with the durability of response sometimes that we see with G12C inhibitors. What do we know about resistance to G12C inhibitors? In short, it can be quite complex. We can see alterations in upstream signaling, such as MET and EGFR amplification, alterations in downstream signaling, such as BRAF mutations or PI3 kinase mutations. You can also see KRAS amplification, as well as alterations in RAF, either secondary RAS alterations or alterations actually that prevent binding in the switch II pocket region. We also see histologic transformation. And among all of these mechanisms of resistance, and in fact, subclonal secondary RAS mutations are one of the most that we see, and perhaps one of the most challenging to emerge. Other thing to keep in mind is sometimes we see multiple mechanisms of resistance ongoing in a single patient in a single time, highlighting the complexity of resistance. So I think that one of the key questions is, can KRAS G12C inhibition be improved to increase the depth and durability of response of these agents? And then ultimately, can we learn lessons from the G12C experience and develop more effective targeted therapies for other RAS mutants? Well, there's many future directions in RAS-targeted therapy, and specifically for KRAS G12C mutations, we're intrigued to think about how can we incorporate these as a part of first-line therapy for patients. Combinations with G12C inhibitors have been tested. Some of our targeted therapy combinations have unfortunately just led to increased toxicity, but not substantial benefit. There's substantial interest in combining with immunotherapy, in part because immunotherapy is so foundational for how we treat lung cancer, both in now the neoadjuvant setting and metastatic setting and the first-line setting. And so the adagrasib plus pembrolizumab clinical trial is looking to answer this question and address it. In early data has been encouraging for patients as first-line therapy. We see the results of adagrasib plus pembrolizumab again in first-line therapy. This was in all patients regardless of PD-L1 expression, and the overall response rate was 36%. However, responses were higher, 61% in those patients with a PD-L1 expression greater than 50%. So these are patients who would be eligible to receive pembrolizumab monotherapy already, but some of these patients do not respond. And so can we improve those response rates with the addition of a G12C inhibitor? Also encouraging is the depth of response. So in all patients, the median progression-free survival was 11 months, median overall survival is 18 months. But when again we look at the PD-L1 subset, in those patients with high PD-L1 expression, such as PD-L1 50% or greater, they show a median progression-free survival of 27.7 months. Now, this is a relatively small subset of patients, only 38 patients, so we certainly need to see this in a larger cohort, but this is incredibly encouraging and suggests that these patients may already be primed to have a response from immunotherapy, and then the G12C inhibition can potentially even enhance this response. What about the safety of the combination? Well, one thing that we would be concerned about is, does the addition of adagrasib and pembrolizumab lead to increased safety signals, potential any discontinuation of either the G12C inhibitor or the immunotherapy that we could overall avoid? And there does seem to be fairly high rates of grade 3 toxicity, nearly 60% of patients having grade 3 toxicities that were observed. The most common toxicity that was observed with hepatotoxicity. And although these can be asymptomatic for patients, do potentially lead to dose reductions and dose discontinuations. And so as a part of these clinical trials, we need to pay attention to not only the rates of adagrasib administration, but also if they translated to any lack of continuation of pembrolizumab for fears of safety. This is not the only immunotherapy combination being explored. We also have olomorasib and pembrolizumab that are in combination. This is another highly encouraging signal. Response rates of 58% in those patients with PD-L1 high disease. And when we see the combination also being tested in chemotherapy plus immunotherapy plus olomorasib, and again, encouraging signals in terms of response rates. Keep in mind when we treat patients with immunotherapy, there is a substantial proportion of patients who have primary progression on this type of treatment. And so the potential to avoid this, we see really good disease control in all of the patients who are treated here. That's an encouraging sign. So there are a number of ongoing KRAS G12C inhibitor clinical trials in the first-line setting. Nearly all of them are combining immunotherapy in some form with the G12C inhibitor, with the exception of sotorasib. One of the challenges with sotorasib is that combining immunotherapy with sotorasib leads to substantial increase of hepatotoxicity, even more so than other agents. So this is really being explored in combination with chemotherapy, specifically in a patient population, the PD-L1 negative population, that may not be benefiting from immunotherapy. So can we adjust the treatment in keeping with what their disease really is? What about the next wave of G12C inhibitors? Well, I mentioned all of the other drugs that are in development right now are inactive state inhibitors. We now have on-state inhibitors that are capable of emitting the mutant form of the RAS protein in its active GTP-bound state. One such example is elironrasib. This is a tri-complex inhibitor or a molecular glue. Sometimes they are also called, and we've seen encouraging response rates that have been presented in patients who are G12C inhibitor naive, so previously treated with chemotherapy and immunotherapy, but have not yet received a G12C inhibitor. Response rates confirmed response rates of 56% in this patient population. But encouragingly, we also see response rates even in patients who've been previously treated with G12C inhibitors. And this is something that we've really not seen when moving from one G12C inhibitor to another before. So certainly more data to come to understand why it is that some patients may benefit from this approach. There are other drugs in development, particularly BBO-8520, that is a G12C on-off inhibitor and capable of inhibiting not just the active state of RAS or the inactive state of RAS, but in fact both. We've really only seen preclinical data so far, though clinical trials are currently ongoing to look at this agent as monotherapy in both the G12C naive patient population as well as the previously treated patient population, either as alone or in combination with other therapies. So moving beyond G12C mutations, how can we target other mutants of KRAS, such as G12D? And we see KRAS G12D mutations not only in lung cancer, but also colorectal cancer and pancreas cancer in particular. We see a number of inhibitors in development. Some of these are off-state inhibitors, such as MRTX1133, which has since been prioritized. Some are on-state inhibitors, such as olomorasib, which we'll talk about in a moment. Others are on-off inhibitors capable of inhibiting the active and inactive conformation of the RAS mutant protein. So olomorasib data was recently presented, and our first hint that this would be effective therapy was actually data presented in pancreas cancer, showing a response rate in 30%. And again, this is a tri-complex inhibitor. But in lung cancer, the results are even more impressive. So this was data that was recently presented at AACR this spring, showing a confirmed response rate of 52% in patients with KRAS G12D mutant non-small cell lung cancer. Keep in mind, these patients with KRAS G12D mutant lung cancer, they are oftentimes women, never smokers. They kind of have a different features than other KRAS mutant lung cancer patient populations. They're more closely similar to an EGFR or something an ALK population even. And so in this group, we saw a median progression-free survival of 11.1 months, hinting that these responses can not just be deep, but also durable. What's also reassuring about this agent is very well tolerated. We do see some nausea, vomiting, and diarrhea, but these are almost exclusively grade 1. Very few instances of patients requiring dose reductions, and very low rates of transaminitis, which have been challenges with other G12C inhibitors. So certainly exciting times for this agent, and more to come in, as well as multiple other G12D inhibitors that are in development. This is an example of a case that we reported, a patient treated with zoldonrasib, a 36-year-old woman with no prior medical history, never smoker, who was diagnosed with stage 3A KRAS G12D mutant lung cancer. She was previously treated with chemotherapy and immunotherapy prior to surgical resection, had her disease resected, had minimal pathologic response, went on to receive atezolizumab as adjuvant therapy, quickly recurred and required radiation and then subsequent chemotherapy. She was really oxygen dependent when she started treatment, and with only a few days of therapy, had improved substantially and was able to come off oxygen. And we can see her cycle 3-day 1 scans here. So really symptomatic improvement as well as radiographic improvement. So this is kind of something that we hope to expect with our targeted therapies when they can be effective, and something that we should continue to explore. I mentioned this is not the only G12D inhibitor that's in development. We also saw data presented at the World Conference on Lung Cancer in 2025 this past fall, showing a response rate in this agent from GenFleet, which is now being further explored as VS3735, showing response rates of nearly 69%. This is an on-off inhibitor, and we do see higher rates of GI toxicity, diarrhea, vomiting, nausea, with more grade 2 toxicity than really only limited to grade 1. So more to come, but certainly an encouraging signal in terms of response rate, and we'll need further follow-up data to see how durable these responses are. So I mentioned that one of the challenges with mutant selective inhibitors, at least from the G12C experience, is that some patients may develop secondary RAS mutations, which really begs the question of, do we need mutant selective inhibitors, or should we try to inhibit all different RAS and do pan-RAS inhibitors? And there are, in fact, a number in development. One of the agents that is further along in development in non-small cell lung cancer as well as pancreas cancer is a medication called RMC-6236, or daraxonrasib. And here we can see the initial safety data as well as efficacy data for patients with non-small cell lung cancer, showing response rates that were presented back in ESMO 2023, response rates of 38%. We saw further follow-up data of a larger cohort of patients when patients were treated with daraxonrasib, and we see that they have a pretty different safety profile than we've noticed from other RAS inhibitors. Not necessarily transaminitis, we see this in rather low grades, more rash and mucositis that are distinctly different toxicities for this agent, as well as diarrhea and nausea. So more data to come. The dose moving forward with this is this kind of intermediate dose of 200 milligrams and not necessarily 300 milligrams, which is being explored in pancreas cancer. We can see the clinical activity in those patients treated with daraxonrasib in G12X or G12C, basically G12D, G12V, G12A, all of those G12 mutations. The drug is also predicted to be active in patients with HRAS and NRAS alterations, as well as G13, Q61 alterations, so it can have quite broad activity. And we can see a confirmed response rate of 38% in this group of patients, and that these responses can be durable with a median progression-free survival of 9.8 months. This agent is now being explored in the ongoing phase 3 clinical trial, the RASolve 301 study, that's randomizing patients to receive daraxonrasib 200 milligrams once daily versus docetaxel. All patients enrolled will have been previously treated with chemotherapy and immunotherapy medications, but not prior taxanes. And the dual primary endpoints are progression-free survival and an overall survival in that core population of patients. And the study is currently ongoing and recruiting patients worldwide. So this is a very exciting time for KRAS-targeted therapies in lung cancer and other solid tumors, including pancreas cancer, colorectal cancer. And what we've learned from our experience with KRAS mutant lung cancer is that some combinations are rational and may lead to more deeper and durable responses, but may also add toxicity. We need to think about how those are going to fit in for patients to be most clinically beneficial, not only in the later line setting, but potentially in the first line setting as well. We also need to think about G12C inhibitor monotherapy. Can we make better drugs that work not only for deeper and more durable responses, but maybe even target difficult to treat areas like the central nervous system, which we haven't talked about today? Can we prevent resistance to G12C inhibitors? Or can we adapt to resistance when it happens with the introduction of other agents? And what is going to be the role of other mutant selective inhibitors and other pan-RAS inhibitors inhibitors in this setting. And ultimately, G12C inhibitors that we know so far are really just the beginning for RAS-targeted therapies. It's an exciting time, and these lessons learned about how we've developed KRAS-targeted therapies for lung cancer are going to apply and inform the development of targeted therapies across other solid tumors with KRAS mutations. I'd like to thank you so much for your attention today as we discuss more about KRAS mutant lung cancer and how we're changing the field in terms of targeted therapies.
Wow, that was an incredible presentation by Dr. Arbour and such an exciting field. I mean, just like it's quite mind-blowing. And maybe I'll start some questions from the audience. First of all, just some bit of background. Presumably, KRAS forms about 30% of our mutations in lung cancer, and there are several subtypes. And at the moment in the UK, principally the focus in clinical practice is on KRAS G12C inhibitors.
Yeah, absolutely. That's right. G12C, as we've heard, we've had in the UK a license and reimbursement for both sotorasib and adagrasib, which are our first generation KRAS inhibitors. We have access to sotorasib and not yet to adagrasib, but that focus has moved forward because obviously those are our first generation inhibitors, and actually we need better and more effective treatments where we start seeing second and third generation of KRAS inhibitors, G12C. But I think that, like we've heard, the direction of travel isn't just as specific to the G12C. It's actually can we improve our efficacy with pan-RAS inhibitors? We've certainly got a number of clinical trials that are open in the UK around KRAS, more potent KRAS inhibitors like divarasib, for example, which is one of the forerunners at the moment.
Can I ask, in the UK, is G12C inhibitors, are they licensed for use on their own or in combination with immunotherapies?
Yeah, so they're just single agent at the moment, and that is in the second and subsequent line of therapy. So that's sotorasib, which can be used after chemo and immunotherapy, or indeed in the third line setting after docetaxel.
It's incredible. I mean, this pace is absolutely so fast. I mean, comparison to EGFR and how long that took. Even before the phase threes are out, you get G12C and then you get the G12D inhibitors. From a timeline point of view, what's your opinion about G12D inhibitors? Do you think that's going to be something that's going to be useful, or is it going to, is it going to be like mutation specific, or are we going to go completely pan-RAS?
I think you're absolutely right there, Eric. I mean, compared to historically, the pace of change in the KRAS space has been so dramatic, and I think that it's difficult to almost design trials in time with the standard of care because we're trying to catch up with the latest developments. And I think one of the greatest kind of developments in recent years is actually the biochemistry. It's actually what we've seen is the biochemistry developments to be able to understand those binding and those inhibitions has kind of almost outstripped the pace at which we can deliver the clinical trials to demonstrate benefit from them. Bringing back to the question about the G12D, yeah, this is quite a unique cohort of patients. They're a bit more like, as we heard, a bit like our EGFR patients. They're often in never smokers. They're a smaller cohort, and again, previously thought to be undruggable. But now we're seeing some of the ON inhibitors that are in clinical trials demonstrating some quite robust and durable responses for those individuals. And this is a clear unmet need. These are often younger, never smokers, and therefore I suspect that we will see, and certainly we've got clinical trials using those inhibitors and others in the UK and beyond, that this will move almost as quickly as we've seen with the G12Cs. Now, the bigger question being, do we want a pan-RAS inhibitor that can to address all of those abnormalities and potentially try and prevent some of the bypass or resistance mechanisms that happen, or do we continue to focus on our G12C, G12D, etc.? Now, what you've seen from the data there is that there's clearly a large and quite different set of mutations and resistance mutations that you get with single agent KRAS inhibition. So there's clearly a need to combine those agents to try and prevent and push back those resistance mechanisms, whether that's with other kind of agents such as immunotherapy, which is what a lot of the combinations have had, or other targeted therapies. If we look to our melanoma colleagues, they knew that BRAF inhibition didn't work for very long, and that's why they combined it with MEK inhibition. We see robust data with that. So my personal view is I think that we should be addressing pan-RAS, but combining that in addition to other agents, because sometimes it's those durable responses, that we see in checkpoint inhibition. You have durable responses, long-term survivors, and how can we combine those so that in this cohort of patients we see those durable outcomes?
That's great. So, Adam, can I ask, the KRAS mutation is about 30% of our lung cancer cohort based on the work that we've done here at the Brompton, and we know that.
Yeah.
And G12C is about 10% of that. So, with the pan-RAS, presumably you cover all 30% of the KRAS mutants in addition, HRAS, NRAS, so on and so forth. Is that right? So, the actual potential number of patients who would benefit is going to be much wider than the 10-20% EGFR cohorts.
Yeah, absolutely. And although we see clearly G12C is our most frequently observed, NRAS and other RAS are just less frequently seen in lung cancer. It's much more typical in other tumor types. But that's not to say that it doesn't form a component of resistance mutations to potentially to oncogenic drivers. So I think there's opportunity also to combine targeted agents based on molecular profiling of maybe some of our more common mutations. We've seen, for example, in EGFR mutations, when we sequence, there's a high number of kind of MET aberrations, and when you combine MET inhibition with EGFR inhibition, you get a robust response in resistance. And there is a space where one would understand that potentially you see those other RAS mutations that develop in response to the EGFR inhibition, where you can combine KRAS inhibitors as well. And I suppose, Eric, the reason why we can do that these days compared to when we've had our first generation kind of inhibitors is that the toxicity profile is much more tolerable. Sotorasib is a good drug, but it can be for some patients quite toxic from a diarrhea perspective, from a liver perspective. But as we see, the toxicity profile is changing, and in my impression is actually more tolerable, and that means that you can combine it with other agents, just as we've seen with other driver mutations.
Great. Question on everybody's lips. Dr. Abida Jelly, Mr. Marchbank are all asking, how about in the neoadjuvant or adjuvant setting? Are you seeing any potential future applications? And again, this is one of the situations where it's developing so fast, and even the advanced space. And now everyone's asking about, hey, how about the early resections? What can we give or do for them?
Absolutely. It's a really difficult space, I think. And as you said, it's moved so quickly in the advanced setting that to move it into the early stage setting is almost a jump too quickly. Now, that's not to say that there are some phase 2 studies in the neoadjuvant setting, these kind of window opportunities, understanding kind of the kind of major path response rates. Now, there are some adjuvant studies. It's a difficult trial to design, I think, because what we know in KRAS mutations is there is an overexpression of PD-L1. Often in those cases, there is quite a robust immunotherapy response, and therefore the order of benefit of the addition of a KRAS inhibitor may be small, and therefore those studies that you need to design are of large numbers. But that's not to say that there are some early stage studies looking at the use of adjuvant KRAS inhibition, some which I won't go through all the details of exactly which drugs, but they are in development. The duration of that treatment, 3 years, is kind of where people are settling in that setting. But yeah, as I said before, it's about manageable tox profile to be able to deliver it in an early stage setting. And are you actually changing the biology to pick up micrometastatic disease? Because if you look to our EGFR kind of space, you do see that, yes, clearly you help cure some people, but there is definitely a fall off in terms of after those 3 years of adjuvant osimertinib, that you then see people progressing. So you're just holding that metastatic disease for 3 years. Now, is that what we're going to see with KRAS? I don't know. I think clearly the answers are the question is still to be answered, and that's why there's clinical trials in this space.
Amazing. Well, thank you so much. And once again, thanks to our presenter, Dr. Kathryn Arbour from the Memorial Sloan Kettering. Such a mind-blowingly good presentation. Next week is ASCO. So we're going to, after that, hear much more new developments, I'm sure. And the week after that is the European meeting. So we will come back on the grand rounds on the 12th of June, and we're going to switch to thymoma, looking at systemic treatment, radiotherapies, and then robotic surgery. So once again, leaves me to thank our sponsors, AstraZeneca, Medtronic, and Medela, the Science of Care, and also to you, Adam. Thank you for your time and expertise for joining us today.
From
Bye-bye, everybody.